Really? I would have liked to have met her.
Yeah, really nice.
All right, well, it's 2:01 or 2:02, so we won't waste any time. Thanks for showing up again this month. We're going over hospice-related stuff, and it's a good thing we bring it up because I can think of a few tags that have occurred in the past that we'll go over. But also, I think there's just a lot of misconceptions about hospice within the community. I think when people come into the building and we bring up hospice, it brings up a feeling of fear, or maybe that it's a death sentence, and that's not necessarily the case. If you ask a lot of people, whether it's a resident or a family member, they'll usually tell you that I wish I would have went on hospice sooner. And that's because hospice offers so many benefits, they pay for so many things, they offer so much more support, and it's not necessarily a death sentence, it's just when you kind of get closer to the end of life and you have these options, it makes sense to utilize them. So both of my grandparents were on hospice. My one grandpa passed away in '06, and he had prostate cancer, and he was fighting that cancer for like 10 years. But I tell you, at the end, he died in the home, and he had hospice care, and it was a wonderful experience. And my other grandpa, he passed away in 2018, and he had diffuse B-cell lymphoma, and he only lasted a few weeks, but he had hospice care, and I was able to see how well they helped us and advocated for us. Even when he was in the nursing home, there were times where maybe we questioned the care of the nursing home, but hospice was always there to step in and talk to the facility and help get things back on track. So there's just a lot of things that they offer. We'll talk a little bit about hospice versus palliative care, because that can be a sticky point. But think back to new employee orientation or annual education, where they bring up that bridge. Remember the bridge? So you start off early in life and you're on this new bridge, and there's no cracks, no holes, nothing wrong with it. And then as you go through life, maybe the bridge starts to crumble in certain places, and then eventually the whole structure caves in. That's kind of what happens at the end of life. So think of the biggest comorbidity, I would say diabetes. So if you're younger and you develop diabetes, let's say when you're a child, something happens to you, there's no doubt that I think your parents would do everything possible to keep treating you aggressively. But as you get diabetes and go throughout life, maybe you develop some issues with your vision, maybe you develop cardiac disease, maybe you develop a gaping wound that doesn't heal, it takes years to heal, maybe that develops an infection. All these things start to build up. So when the big medical event happens, there really isn't much, there's really no way to treat it at that point. So that's where hospice can come in and bridge that gap for us. So this particular PowerPoint is more about the regulations related to hospice. I'm going to skip over some things that I don't think are relevant, but the objective more or less is to be able to verbalize what the healthcare facility should be doing while someone is on hospice. So the F849 basically states that a nursing home facility has the right to offer hospice care to a resident, or it can choose not to offer hospice care to residents. And if it chooses not to offer hospice services, that's okay. That just means that the facility has to arrange for a transfer elsewhere. So that way the resident can get hospice services. If the facility does choose to bring in a hospice servicer, it has to be a legitimate company, a legitimate entity that has a set of professional goals and standards. If that's not there, you can't go through it. So right now, we utilize Mayo Red Wing, which has been pretty much our gold standard hospice company, which has been great. Kim is always there for us. St. Croix, we started using them, I would say, we signed a contract last year at some point. Yeah. And that's just because a resident wanted St. Croix, and it turned out to be a really positive experience for us as a facility. So we usually lay those two options out right there. And I know there's one more company.
This is Heartland.
Heartland,
Yeah.
that's the one I was thinking of, yes. There are a few people here and there that use Heartland, but it's very far and few and in between. So what is so much fun is that when we sign on to a hospice company, there has to be an agreement. And that thing is like this thick. And it goes in the DON binder, which I'm sure Carol now faithfully updates every week and getting ready for state. But it has to lay out all the services hospice will provide. It has to make sure that we're gonna do our part and we're gonna keep administering meds and do our bathing and feeding them and monitoring them, and they're gonna come in and provide support. We'll talk a little bit about the support here in a minute. So, yeah, the regulation here is that the facility remains responsible for administering all the therapies, those that hospice determines, and then those that us determine. So I had a discussion with Dr. Foss once because I didn't know who to go to first. So when a resident declined or needed something, the question was, do we go to the primary care provider first, or do we go to hospice first? Who's the entity that has custody of the resident? And the answer is hospice. Hospice is the group that takes over. Hospice has their nurses, they have their medical director, they funnel things up, and then we update the resident's primary care provider. Now it's kind of a collaboration because the primary care provider also does rounds for their regulatory guidelines, and we have to update them on any changes. But just a thought, if a resident needs something, go to hospice first as opposed to the primary care provider. Number 3 is one that we could get tagged on. So I'm thinking of my last facility. We had a resident that was on hospice, and this wasn't a big deal, but she started speaking up more, getting louder, maybe just being kind of disruptive. It wasn't hurting anybody, but it was something that was noted in the charting. And the piece of that got us was that the nursing team didn't update hospice. So when state comes in and interviews hospice, hospice kind of threw us under the bus and said, well, I didn't know about that. I could have managed that. And that's where the integration comes in. Now, I really don't think we have an issue with that with our hospice team. Kim comes in at least every week, if not twice, and she works very closely with Tammy and Catherine. But one of the regulations that we have to maintain is making sure that we have a point person for the hospice team that comes in. And the point person is always going to be the unit manager, because they're going to make that connection. They're going to talk about everything that happened from the last week, and then they're going to do their assessment. On that same note, when hospice comes in and they admit someone, they're going to create a care plan for that resident. That care plan needs to be integrated into our care plan. It doesn't necessarily have to be word for word, but all those main points about pain control and honoring wishes, all those things need to find a way into our care plan. And then our care plan, on the other hand, has to be updated as well. So we can't say, well, I would hope that none of our hospice residents have full code, because they can't have that. But it's those little things like that that could really trip us up. Hospice versus palliative care. When I first started as evening charge, I got a call from a resident's daughter, and she wanted to know the difference between hospice and palliative care. Now, I was on break at the time, and I wasn't really ready, so I kind of fumbled through it, and I didn't really know. But in short, everyone that lives here should have more of a palliative approach to their care. So what that means is we're going to try to make them as comfortable as we can while we treat them. So if someone has dementia, and that dementia is starting to cause a lot of anxiety, we want to work to treat the anxiety. so the dementia effects aren't as bad. That's a form of palliative treatment for dementia. Or if someone develops COPD and the COPD is causing insomnia at night because they can't breathe, now we want to work to treat the insomnia so they can sleep at night. That's a palliative approach for COPD. Or if you have cancer and you want to take Zofran to help with nausea or upset stomach, that would be a palliative approach for the cancer treatment. So it's doing things to maximize comfort while you're still giving treatment. So someone that's full code can still be palliative. That's absolutely fine. Hospice, on the other hand, that's taking palliative to a whole new level. So the hospice care is the formal program, and that's where someone only qualifies if they have 6 months of life left or less. And whether we know someone is dying or not, we can usually start to look for those subtle signs. So weight loss is a big one. If someone's triggering at 10% weight loss on their MDS, that might be a reason to get an assessment. If everything we've done to manage the weight loss fails, we might think hospice. If a resident doesn't want to take their meds anymore, another reason to maybe consider hospice. 2 terms that we want to define. First one is terminally ill. You'll hear this a lot. This is when someone has 6 months of life left or less. Bereavement counseling is just, it's about being there before death, during death, and after death. And hospice is really great about bereavement. So if someone dies at 1 a.m., you gotta pick up the phone, you gotta call hospice, you gotta tell them, and the question they're always gonna ask is, do you need me to come in and be there for the family? Most of the time, the family says no. Sometimes they'll say yes if they're pretty distraught. But they'll provide that bereavement counseling after death, and I think up to several months after the death, if that's needed. What's really sad is that the psychology services in our region are slammed. It is really hard to see a psychologist right now or a therapist of any kind. So utilizing any type of bereavement counseling for the trouble that you're having, accepting a death, is really to your benefit. And hospice can provide that. I brought up the hospice attending physician. That's Dr. Melstrom for us. Megan Herbers also helps to do a lot of those regulatory visits for hospice, which is nice because she also sees our residents who aren't on hospice. Helps bring everything together. Nursing home communication. So everyone should be aware of where the advanced directives are. In our medical record, it's just in the front of the chart. And that's where you're going to see the pulse. Everyone on hospice, it should say DNR, so do not resuscitate, DNI, do not intubate, and do not hospitalize. If you see anything different, our goals of care will need to be discussed, but it's kind of a deal breaker. You kind of have to be DNR, DNI, and hospice. One of the perks of hospice is that they really want to focus on the residents' wishes. So if a resident values seeing a chaplain often, they're going to make that happen. Daniel Crapo, I think that's his name, comes in a lot to see our residents. And I didn't know who he was at first, but I'm seeing him all the time now. It's just wonderful. Does Debbie White bring her dog in yet? No, not right now.
I don't think we told her that she can yet.
Okay. More perks, more perks. I actually wrote down 5 really good reasons why someone would want to consider hospice. The biggest one, and people love this, Medicare pays for all the hospice services. Now, it doesn't mean room and board in a nursing home. It means all your medications, all your equipment, the nurses that come in to see, the social workers that come in to see, the doctor visits, the chaplains, it's all covered. So even when someone's in the home and they don't have that room and board to pay for, it's this free Medicare benefit that you really just can't beat. Second reason, hospice improves your quality of life. Again, people that get those frequent nurse visits, get that extra TLC, they have that 24-hour phone line to the nurse to get pain medications increased or other issues addressed. You know, it's actually said that people that get on hospice as opposed to not hospice live a little bit longer. And it's because of this really good care that's being given. Number 3, hospice puts your wishes at the forefront and center. Number 4, hospice improves communication between the healthcare providers. And number 5, hospice builds relationships through the long-term support that they provide. As I said before, in order for us to stay in compliance, we have to make sure that we are very timely updating the hospice team of things that change. When a resident has a change of status and they're on hospice, it could very well be the end. So it's a phone call that we can make anytime, day or night. If it's something small, if a medication needs to be changed, we can wait till the next day. But anything big, even if it's just behaviors, it's something that we have so much more control over when the person is on hospice compared to not on hospice. We should definitely take care of that opportunity. Again, our responsibilities, it does not matter whether someone is on hospice or not. We still gotta feed them every day, we still gotta give them baths, we still gotta give them meds, we still have to treat them the same as every other resident, but the hospice team might provide a bath aid. So you might see the Danielle come in every once in a while and give a bath. It takes a little bit of the workload off of you guys. Hospice can also provide volunteers at certain times of the day. If someone's dying, nobody should have to die alone. They can work to fix that. Talked about responsibilities. Don't forget this one from last month, reporting abuse and neglect. We have to do that for everybody, hospice or not. And then hospice, they have a lot of responsibilities as well. So when they come, they're gonna write a note in our point-click care that we can review. They're gonna summarize all the things that we talked about when we did the one-to-one visit with them. We can always review their written agreements if we have to. They will be there to give support to the staff if they're having a difficult time. They'll also help with education if needed. Rochester Mayo Hospice was really good about that after one of the deaths. So nothing beats support, and that's really what it comes down to, is that we want to report things because they're there to give us support. All staff, they have responsibilities as well. And again, if you see something different with the resident, just report it to Tammy, to Catherine, to social work, and then they can coordinate with hospice. If you guys get questions about hospice or palliative care, I'm hoping you have a little more information now to answer the questions. So that's kind of our summary there. Any particular questions?
I just want to mention that if somebody's having difficulties after the death of a resident or a loved one, whether they're on hospice or not, you can always utilize your EAP. And if you don't have that number, you stop and see myself or Matt as your supervisor.
Yep, thank you. Well, with that, we'll just run through the questions here. So, number 1, the facility needs to appoint a representative to work with the hospice representative.
Sure.
Yes, and that is your nurse managers. Number 2, the nursing home resident should not experience any lack of services because of the fact that they're a hospice resident. Right. They should get more. The same amount from us, but hospice tax on that extra support. Okay, number 3, all changes in resident care plans can be communicated to hospice at the quarterly care plan meeting. Oh, you guys are good, that's the one they're supposed to check you out. Yeah. Quarterly, it might be too late. Number 4, hospice assumes responsibility for determining the appropriate course of care, including the determination of the level of services provided.
Sure.
Yeah, so, you know, our MDS nurses work to set the payer rate and that stuff, but hospice can say, you know what, we need to come in more, or we think you guys should provide this treatment more, they can do that. Number 5, palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, spiritual needs that facilitate patient autonomy. Yeah. And number 6, we gotta have a written agreement if we use the company, right?
Yeah,
Good, you mastered it.
Woo-hoo.
Thank you.
Thank you.